Thank you for joining us today for UAMS Insiders Lunch with Leaders. I'm John Irk, Vice Chancellor for Institutional Advancement at UAMS. In advancement, we are tasked with generating support for 6 academic medicine units, a world-renowned comprehensive medical center that includes 7 medical institutes and 8 regional campuses across the state. Our UAMS Insiders Lunch with Leaders events are designed to keep our invested partners, alumni, and donors connected to our ongoing work. You are among the first to hear about new research, technology, programs, and projects that are improving the health and lives of Arkansans. Today, we have the pleasure of welcoming Dr. Timothy Langford. Dr. Langford is a professor and chairman of the Department of Urology. Dr. Langford is a lifelong Arkansas resident and UAMS graduate with nearly 3 decades of experience in urology. He is a highly regarded urologic surgeon and leader in the field who brings superb experience and clinical leadership to the organization. He comes to UAMS after a 28-year career at Arkansas Urology, where he served as president since 2011. Dr. Langford treats a wide variety of urologic diseases, including BPH, kidney stones, erectile dysfunction, prostate cancer, urinary tract infections, urinary incontinence, and bladder cancer, to name a few. During today's talk, Dr. Langford will provide a brief update on the vision of the UAMS Department of Urology and its effort to meet the growing needs of Arkansans throughout expanded specialty care, innovative education and research, advancements in technology, and broader access to quality urologic care throughout Arkansas. He will also discuss the new UAMS Urology Center in West Little Rock. Please welcome Dr. Tim Langford.
Thank you. It's a privilege for me to be here to talk about some of the advances in urology and innovation in our department, our burgeoning department. I want to thank John and people like Melinda Spradling, everyone who made this event possible. I want to welcome everybody watching. I've been at UAMS now for 2 years, and I can tell you that I've loved every minute of it. I mean, we've had challenges, but everywhere I look, there are resources, there are people willing to help. I love the mission. I love the vision that people like Chancellor Patterson and our CEO, Michelle Krause, have given. And, COVID was tough on our Department of Urology. At one point, we were down to 2 faculty members, and our residents were seeing a lot of changes. But I can tell you, fast forward 2 years, myself and our vice chair, Dr. Julie Riley, we were both college athletes. We believe in team. So we've tried to develop a culture of team and accountability and discipline. And I can't say enough about our faculty and our residents pulling together, building a firm foundation. We've really tried to stabilize our clinical operations. We've even been able to expand our clinical operations and provide better access. So it's an exciting time. A lot of people are responsible for where we are. So let's get to the basics. What is urology? Urology is also known as genital urinary surgery. It's the branch of medicine that focuses on treatment of the urinary tract of men and women and the reproductive tract of men. So what organs are under our domain? The kidneys, the ureters that take urine from the kidney to the bladder, the adrenal glands. These are small glands on top of the kidneys that regulate sugar and our immune system and blood pressure. Obviously, the bladder and prostate, the reproductive organs. I left out the urethra. 2 of my faculty members would be very upset with me on that because they specialize in disorders of the male urethra. So I want to include that. Just a brief history of our department. We were initially a division of the Department of Surgery. We became a department in 1975 under the leadership of Dr. John Redmond. And historically, we've had a strong clinical program that trained urologists for Arkansas and surrounding states. And don't get me wrong, we have alumni of our program who are fellowship trained and doing well in places like Memorial Sloan Kettering, the University of Arizona. But really, we're a community-based program. I will say also that in the last 5 to 6 years, we've had 3 of our alumni go on to get further training in fellowship areas such as robotics, male reconstruction, male infertility, The residency program adds 2 residents a year. So it's a 5-year program. We have 10 residents. We have 4 sites, obviously UAMS. We have one of the busiest VAs in the country, Arkansas Children's, and Arkansas Urology for a private practice rotation. We have 3 endowed chairs that are very instrumental in our department for funds to help with research, with education. We have the Robert Woods Bass Senior Distinguished Chair in Genital Urinary Oncology, the Hal Reed Black Chair. Dr. Julie Riley, our residency director, was recently became the initial chair holder, and the Stephen Wilson Chair in Prosthetic Urology. The first and third currently are not filled, but we have a plan to have those 2 chairs filled in short time, hopefully. What is our vision? We want to build a team of experts in the major disciplines of urology to provide comprehensive care for Arkansans. This is oncology, pediatrics, endourology, which is using scopes and robots to take care of kidney stones and kidney problems, male urology, which encompasses male reconstruction, erectile dysfunction, incontinence, and then female pelvic health. We want our patients, we want our Arkansans to get their care here and not have to travel to Dallas or to Vanderbilt, Nashville, or Kansas City. We want to embrace an innovative educational program to provide comprehensive urologic training. We want to train and raise up leaders to go out to Arkansas and be fully trained. We're including things now like business. We're introducing leadership curricula and wellness. We want well-balanced urologists. Develop a robust urologic research program. We're very involved with research. That's not been a high focus in our program, but we want to develop a culture of curiosity. We want to be collaborative in addressing the challenges in urology in Arkansas. Workforce is the biggest, and I tell the urologists around the state, I work for you, and we want to be partners in meeting these challenges, especially addressing the healthcare disparities in the care of all of our urologic patients. How's our department set up? Our structure is we have 2 service lines. We see patients at the Cancer Institute. We also see patients, we're a part of the surgical services, which is general surgery, ENT, plastic surgery, et cetera. We're up to 5 faculty, 10 residents, like I mentioned. We have 4 advanced practice providers, and they are crucial for us in providing better access. We have a department RN and 3 administrative staff. So I really can't talk about advances and innovations without first talking about the UAMS Health Urology Center. I didn't ask a lot. I don't think I asked a lot when I became the chairman, but I did ask for a new site where we could see our non-cancer patients. And I never dreamed of something like this. This is a 30,000 square feet facility, I believe it is, located in the Premier Medical Plaza at the corner of Rodney Parham and Shackelford. It has been transformative for our program and most importantly for our patients. It's composed of a urology clinic, a urology-based outpatient surgery center. We also have diagnostic imaging, and we also sit right by our colleagues in interventional radiology. So for us, the clinic we had here on campus, we've gone from 7 exam rooms now to 15 exam rooms. We've gone from 2 procedure rooms to 4 procedure rooms. You can see how the lighting, the efficiency, the workflow has just changed the whole morale of our nurses and all of our providers. We have all the advanced technology. We have MRI fusion prostate biopsies. This is software that can take an MRI and lay it onto our ultrasounds that we use in the office. We have urodynamics. This is sophisticated equipment to evaluate voiding dysfunction, especially in spinal cord patients, so we can provide better care. Point of care ultrasounds. We have ultrasound machines everywhere in the rooms. We can measure bladder volumes, prostates, et cetera. We've adopted the use of disposable endoscopes. This has made us much more efficient. We don't have to worry about breaking scopes, repairing scopes, and our goal, I think we were seeing 3,000 or 4,000 patients a year coming out of COVID. Our goal for 2024 in this new facility is 8,000 patients. Our goal as a department is 9,000 patients. And if we keep going like we are, we're going to blow past that. The UAMS Urology Surgery Center. So this has been a multidisciplinary effort with perioperative services, our nursing staff, our anesthesia staff, the urologist. This is a state-of-the-art facility. We have the newest in imaging and lasers and scopes and software. Most importantly, we have a team that has embraced this, and they want this place to excel. They want to be efficient, and they are doing that. We keep adding on cases because they're so efficient. And they want this to be a place where the patients are well taken care of, and we get great outcomes and patient satisfaction. I would say this has really put us on the map. I would venture that academic medical centers, I don't know of another academic medical center that I'm aware of that has a facility like this. You know, when you look at a program, you say, what can we be best at? And we can be really good as anybody in the country, in my opinion, in advances in kidney stone management. We're in the Sun Belt. We're in the Stone Belt here in Arkansas. Dr. Julie Riley is an endourologist that I was fortunate enough to recruit from New Mexico. She's a vice chair, our program director. She did an endourology fellowship. This is training in small miniature scopes, taking care of kidney stones, robotics, kidney disorders, ureteral disorders and blockages. She also performs renal transplants, and she has been very instrumental in our transplant program, taking care of some of the complications that occur with those patients. So what are our advances in kidney stone management? I put number one, the kidney stone prevention program. Dr. Riley is passionate, not just in treating stones, but preventing stones, because once you have one, you have at least a 10% chance per year of having another stone. And she has developed a pathway where we're doing 24-hour urine tests, blood tests, education, and helping our patients prevent further stones. She's an expert in flexible ureteroscopy. These are miniature scopes that keep getting smaller and smaller that can go up into the kidney and ureters and get multiple stones with all these new lasers. She also treats strictures, scar tissue in the ureter, tumors. We have all the latest in laser technology. I can tell you that our third-year residents are probably better than I was after 30 years at taking care of kidney stones. She also does percutaneous nephrolithotomy. These are larger, more complex stones. Instead of making a big incision, these are 1-inch incisions. She goes in with small trocars or cannulas, so to speak, again with lasers, and often can clear out a kidney full of stones with a one-night stay in the hospital. Advances in urethral stricture disease. Dr. Brian Langford, yes, we are related. Have you ever heard of the old basketball coach, John Wooden? He said, if you parents who coach their kids are either half as hard or twice as hard on them, I'm a twice as hard dad, unfortunately for Brian. But I will say he is the first alumnus of our program. So he did medical school here. He did his residency here. He went to Dallas to UT Southwestern and did a fellowship in male reconstruction and prosthetics and trauma. He's the first alumnus we've had to come back and come on faculty. And this has been a real gap. Male reconstruction has been a huge gap in Arkansas, and we're filling that gap with Brian back, especially in urethral stricture disease. So the urethra in men takes urine from the bladder, and Brian set up a pathway of working with our radiology department of really good imaging. The imaging of these urethral strictures can be difficult. We're getting good at that. Balloon dilations. This is a non-invasive way to take care of these strictures. And he'll be doing the Optaloon. This is a new device that balloon dilates a stricture and releases medication into that tissue to keep them from coming back. And it's 75% successful. And he's also performing open urethroplasties. This is open surgery to cut out the scar tissue using grafts and with a 90% success rate. And I can tell you the urologists around the state are glad we have this program, and Brian's getting busy very quickly. Next, we have Dr. Bruno Machado. Dr. Machado actually is fellowship trained in laparoscopy. He is our workhorse. He is the most versatile urologist in our department, and he has a real passion for Peyronie's disease. And this has been another gap in Arkansas. What is a Peyronie's disease? You don't hear about it a lot, but it's very common in men. It can be very disfiguring. It can really hamper and impact a patient's quality of life, a couple's quality of life. So it's formation of scar or plaque in the outer layer of the penis. And it results in curvature, narrowing, shortening, or erectile dysfunction. Dr. Machado and Dr. Langford are developing a Peyronie's treatment pathway consisting of both non-surgical and surgical techniques. Non-surgical includes injecting substances that can dissolve these plaques. And now we're able to fix these plaques with two different techniques, plication or excision with grafting. So we can be regionally prominent in the treatment of Peyronie's disease, and they are doing research in this area. Advancement in benign prostatic hyperplasia. This is benign enlargement of the prostate in men, causing difficulty with urination, getting up at night. We have tried to be more accurate in our diagnosis using scopes and imaging. Every prostate we have different treatments for different sizes and configurations of the prostate. The gold standard, probably everybody has heard about, is TURP, or transurethral resection of the prostate, or in layman's terms, the old Roto-Rooter. We have much more refined techniques now that are minimally invasive, outpatient. We have the UroLift, which is using implants, takes about 10 minutes. Water vaporization, called Resume. Dr. Riley has done the first laser enucleation procedures called HOLAP, holmium laser enucleation of the prostate. And this may replace all of them. It's a phenomenal technique. Patients leave the hospital the next day without a catheter with large prostates, and there's no one in the state. And historically, we've had to send these patients to either Vanderbilt or places like Indiana to get this treatment. We have robotic approaches for large prostates. One of our interventional radiology colleagues, Dr. Robert Dixon, is doing prostate arterial embolization. He can stop the blood flow of the prostate and shrink the prostate by about 30%. So all this to say is we have a multidisciplinary comprehensive program for one of the most common urologic problems, BPH, and we want to be the place to go in Arkansas for men with BPH. Last but not least is Dr. Murat Aydin. He has led our efforts and advances in urologic cancer. Dr. Aydin did a fellowship in urologic oncology at the Moffitt Center, a well-known cancer center, freestanding cancer center in Tampa, Florida. He's really brought an evidence-based approach, an innovative approach to management of urological cancers. So this is September, is Prostate Cancer Awareness Month, prostate cancer screening. Historically, I have to admit, we have probably overdiagnosed and overtreated prostate cancer. We are trying here at UAMS to be more strategic and diagnosing the men that really need to be diagnosed, and maybe not doing all these unnecessary biopsies. So we're using biomarkers. These are urine and blood-based tests to tell us which men may have a significant cancer and which ones don't have to have a biopsy. That may eliminate 75% of men, and it's very effective, it's more accurate, and it's less costly. If the markers do indicate a problem, our radiologists are excellent at reading and performing MRIs of the prostate. And this can show us lesions where we can be much more accurate and precise when we do have to do a biopsy. Some of the screening with COVID has been lacking, and we're seeing an inverse stage migration of prostate cancer. We're seeing more advanced cases. We have a multidisciplinary team at the Cancer Institute, not just urologists. We have radiation oncologists, medical oncologists, pathologists, radiologists, interventional radiologists who are experts in advanced prostate cancer. So we're using scans such as the PSMA PET scan. This is using molecular imaging to find prostate cancer that's advanced much sooner than CAT scans can, bone scans can, and patients can get their treatment earlier and have better success rates. Our radiation oncologist, Dr. Sanjay Marabonya, has led the efforts on stereotactic body radiation therapy. I didn't even put proton beam therapy. We're going to start treating our first proton beam patients with prostate cancer next month. And that can be a game changer. Theranostics, this is taking the diagnostic capability such as PET scans and coupling those with immune and other agents and basically unleashing the immune system on prostate cancer. And this is the newest treatment, and it's done right here at UAMS. In the interest of time, I can't mention all the things we're doing. We are very involved, the whole team, in bladder cancer and clinical trials. Same in kidney cancer. Dr. Iden is doing some translational research in immunotherapy of kidney cancer. So we're trying to be innovative and build our radiation efforts. So what are our plans for the future? We need to add another urologic oncologist. Dr. Iden's gotten very busy. I've been doing probably more oncology than I need to be doing. So we have 4 candidates visiting here in the next few weeks. And hopefully we'll hire one of those soon to add to our team. Female pelvic health, that's a real gap in Arkansas. And we are trying to recruit. This is difficult to recruit anywhere, but especially in a rural state, a urogynecologist. But we're going to keep doing that. Voiding dysfunction experts. We need someone who does specialize in taking care of our spinal cord patients, our patients with multiple sclerosis and Parkinson's disease who have complex voiding dysfunction. And outreach. We want to, I'll just say, Dr. Riley and I feel a huge burden and a responsibility for the workforce in Arkansas. And I failed to mention, we've sent our 2 residents who graduated from the program last year went to Pine Bluff. Next year, one will go to Pine Bluff, another will go to Batesville. The year after that, another one's going to Batesville. We want to train urologists. We want to send them out to the rural areas of Arkansas so they can go to Monticello for satellite clinics and take care of the patients in Star City and Texarkana, et cetera. And we want to have outreach clinics. Now, we're probably 2 or 3 hires away from helping with satellite clinics, but I know we have the satellite clinic in El Dorado. We have the Cancer Institute, the outreach programs. As we recruit and add to our team, we want to be involved with outreach. So that's all I have right now. I want to thank you for this opportunity again, and I'm sure John will probably have some questions for me.
Thank you, Dr. Langford. It's a great presentation. We've got a few questions that have been submitted, so we get started with that. We all know somebody who's had kidney stones, and you talked a little bit about the kidney stone prevention program. Can you tell us a little bit why that's so important?
Yeah, like I said, that we're in the Stone Belt, and we have the humidity. Patients get dehydrated, and we see a lot of stones in Arkansas compared to other states. And it's very costly for patients. They miss work. Their employers, there's a huge economic cost. I think we've spent $5 billion a year in the United States on stones. It's a very painful condition, and long term, it can cause kidney dysfunction, the loss of a kidney, lead to transplant. So it's really important, number one, to have great therapeutic options, but really the prevention is what we're really focused on right now. And what I can just say is, I think a lot of patients do, after they've had a stone episode, they want that help in trying to prevent it. So we're trying to diagnose them, find out the specific metabolic problem they have, work with them on changing their diet, putting them on supplements, putting them on medication. So it's a huge health and economic burden that we're trying to address.
So what are some quick things that we can do to try to prevent it?
Great question. I'm glad you asked that. Number one, we tell all of our patients, drink lots of water. They say 2 liters of water a day. I tell patients your urine should be clear to light yellow, and limit your salt in your diet. Those 2 things right there will help help most stone formers decrease stone growth and new stones.
Right. So you also mentioned some of the advances in prostate cancer screening, and September is Prostate Health Month and Prostate Cancer Awareness Month. At what age should men begin screening And what are some
Yeah,
important things?
Great question. Again, we, as urologists, I think we've confused our non-urologic colleagues and the public in general about screening. Recently, the American Urological Association said men in 45 to 50, I think, should have an initial baseline PSA. If you have an increased risk, African-American, a family history, it should start at age 40. If there's one message I think that I would like to get out to men is get a baseline PSA in your 50s, 60s. If it's less than 1, you virtually have a 0% chance of having significant prostate cancer over the next 10 plus years. And that eliminates 77% of men right there. And let's focus on the 23% of men with a PSA, that's prostate-specific antigen we use for screening of prostate cancer. Let's focus our efforts on those men.
Right. What are some of the main challenges that you're faced with in urology, and maybe specifically in Arkansas? You mentioned we're in the Stone Belt. Are there other geographically?
2 things that keep me up at night, that get me going in the morning is workforce, for sure. We've not really increased the residents and training of urology since the late 90s. And for instance, when I started 30 years ago in Arkansas, I think we had a population of 2 million and we had 75 urologists. Now we have a population of almost 3.5 million. I think we have 55 full-time urologists. So workforce burden is huge. And I think we do that by accepting Arkansans into our program, trying to keep them in Arkansas when we can. We are focusing on advanced practice providers, finding them, hiring them, training them. One day I'd love to have a year of extra training for an advanced practice provider. That's an APRN, a PA in our program to go out in the state. So workforce and then burnout. I think urologists are so busy. I really talk to our faculty and our residents. We try to have a wellness program, do things fun as a group. Those are probably the 2 biggest challenges, 1 and 2 as a chairman.
Right. You mentioned a lot of male urological issues today. What are some of the advances being made in female urology?
So female, I don't know if you've heard, the female urology really took a hit in the meshes that came out, causing a lot of problems, a lot of legal action. So the main problems in female urology are incontinence, pelvic prolapse, relaxation of the pelvic floor, and overactive bladder. We all age around our bladders, and this causes problems with incontinence. It causes problems with pain. And I think now the focus is minimally invasive procedures for female stress incontinence, trying to use not meshes, but biologic materials to repair pelvic prolapse, and robotics is entering the picture there. And then some of the newer things for overactive bladder or Botox in the bladder, and using what I call pacemakers for the bladder. It's called sacral modulation. So these are things that we have our eye on, and that's why we really want to work on recruiting a female pelvic health specialist to UAMS.
What about some of the current research that's being done within the department pertaining to urology?
So Dr. Iden, I mentioned he's doing some research in kidney cancer. He also is very involved with our clinical research, prostate cancer, kidney cancer, bladder cancer in the Cancer Institute, and helping with the NCI efforts. Dr. Machado, I mentioned, is doing, he's really becoming an expert in Peyronie's disease, what's causing that, how can we treat that better. Brian Langford is going to start doing research in these surgical techniques for men for erectile dysfunction and stress incontinence. Dr. Riley is looking at health disparities and kidney cancer. How can we get these patients to treatment quicker? So those are probably our main efforts right now in research.
Well, this question's close to me. Why is philanthropy so important to the work that you do?
It helps every aspect of our mission. For instance, that's why we'll get these endowed chairs all filled. There's funds that flow from those for education of our faculty, education of our residents, research. We've had some generous donors give funds, unrestricted funds, and we've used those for research. We've used them for clinical support. We use them for recruiting, and again, every aspect. And in academic medicine right now, the margins are slim due to supply chain and labor. So it's just vital for the growth of our department.
Great. Well, now you talked a little bit about the clinic in West Little Rock. What are some of the improvements that you've seen? Is it improving wait times or
I'm glad you,
access?
yeah, I should have gone in more detail on that. I'm excited for our residents to see their eyes when they first walk in there, but I'm most excited for our patients. They can now drive in the parking lot almost to the front door, and it's so convenient for them.
Mm-hmm.
And they walk into this clinic and it's bright, it's spacious. So we have more access. The problem is the word's out, we're getting busier and busier. So the wait times got down. They're starting to get a little bit longer again, but we do have shorter wait times. So far, the new clinic has met rave reviews from our patients, and hope that continues.
Great. And along those same lines, sometimes it's difficult for people to get to Little Rock. What's sort of the plan or the outlook in terms of expanding urological clinics throughout the state?
So we're really looking at, as we expand our faculty, that's one thing that we want to be able to do is go to places like El Dorado. I'm from Searcy. Searcy used to have 2 or 3 urologists. Now Searcy has 0.
Mm-hmm.
Russellville used to have 2 or 3 urologists. They have 0. We want to go to these communities and provide care with our faculty, with advanced practice providers, so that patients can at least get their initial evaluation and get some of their follow-ups at home. I mean, we still need to come to Little Rock for some of the sophisticated imaging and procedures, but that's our plan, John, is to focus on communities like that.
Any thoughts about how we can increase the number of students interested in urology, or what? We
are seeing more interest. I think we had twice as many students apply for our program. We're seeing, I think with this year we had 5 or 6 medical students do rotations with us, and it used to it was 1 to 2. So students are getting interested. What we need to do is find ways probably to increase the number of residents that we can train. We need to go from 2 a year to 3 a year, and if we could put out 3 a year, and if we could keep half of them in Arkansas, in the next generation, that would pay huge dividends.
Right. Well, I think that's all the questions that we have. Did you have anything else that you wanted to add on top of that?
I don't think so.
Okay.
It's an exciting time to be in urology. Like I said, so much support. I love the learning. This has been around the residents. This has kind of revitalized me, and very optimistic for the future.
Great. Well, thank you, Tim, for being here today and sharing your expertise. And thanks to you for tuning in today. Please stay tuned for more information on upcoming UAMS Insiders Lunch with Leaders events. You'll receive an email with more details on future presentations, and you can visit giving.uams.edu/insiders to view past presentations. Thank you, and we'll see you again soon.